It's an honor to introduce Emory Brown, who is currently Professor of Computational Neuroscience in Health Sciences and Technology at the Massachusetts Institute of Technology, as well as the Warren Zapol Professor of Anesthesia at the Harvard Medical School and Massachusetts General Hospital. He received his BA in Applied Mathematics from Harvard College, his MD from Harvard Medical School, and his PhD in Statistics from Harvard University. He completed his internship at the Brigham and Women's Hospital and his residency in anesthesiology at the Massachusetts General Hospital. Emory Brown is currently, has had a really distinguished record, and as a result, he's obtained more honors than I'm going to be able to go through. So I'll just mention a few things. He is a fellow of the American Statistical Association, a fellow of the AAAS, and a fellow of the IEEE. He's a member of the Institute of Medicine, and in 2007 he was the recipient of the NIH Director's Pioneer Award. He's also currently serving on the NINDS National Advisory Council. Storyland has particularly wanted me to mention that. As an example of how many institutes are throwing money at him, he is a principal investigator on NIH grant funding from NIMH, NIGMS, NIBIB, and NIDA. As co-principal investigator, there's many more institutes that are giving him money. Over the course of his training, there are a couple of interesting facts. For a decade, he was co-director of the Woods Hole summer course in neuroinformatics, which he finally gave up in 2007. And he tells me that his children have not yet forgiven him for stopping spending summers on Cape Cod. Another interesting point, I thought, was that his first 4 papers one was in experimental eye research on the goldfish retina anatomy, one was in Science on circadian rhythms, one was in Biometrica on characteristics of harmonic regression models, and one was in the New England Journal of Medicine on therapies for shift work. I think this really illustrates the great breadth of his thinking, and that was just the start of his career. As with many of the scientists who come to the Walls lectures, he has a strong basic science record with papers in Science, Neuron, PNAS, Journal of Neuroscience, Journal of Neurophysiology on the neuroscience side. He also has papers in neurocomputation, neurocomputing, IEEE transactions on the more statistical side. And on the clinical side, he has peer-reviewed articles in JAMA, New England Journal of Medicine, Lancet Stroke. Finally, I'd like to say that Emory Brown says of himself that he is an anesthesiologist statistician whose statistical research develops signal processing algorithms to study how neural ensembles represent and transmit information, or how we think. His experimental research uses functional neuroimaging to study how anesthetics create the state of general anesthesia in the human brain. His talk today is a look at the unconscious brain under general anesthesia. Thank you, Emory Brown.
So thanks a lot, Richard, for inviting me and for making this a fantastic visit. I'm going to tell you about the work that we've been doing, the work which is actually supported by the Pioneer Award. to look at to try to understand what happens to the human brain under anesthesia. So I've entitled it The Dynamics of Loss and Recovery of Consciousness Under General Anesthesia. And I want to try to give you some sense of what we've learned in conducting these studies. So I'm going to talk primarily, although we have studies ongoing in both humans and animals, I'm going to talk about the human studies today. Some of this I discussed maybe a year and a half ago, and I'll bring you up to date on where we are, in the last, since then. So, I have the good fortune to work with a number of people, and so I just wanted to highlight some of these folks before I start, because I'm going to be talking about their work. I mean, I just sit there and go, yeah, go guys, go, that sort of thing, So, Patrick Purdon, Eric Pierce, who've been really doing a lot of the work on the human studies I'm going to talk about, John Walsh, Grace Harrell, Kevin Wong, Eileen Semenser, Shinung Chen. Shinung's been doing the modeling work I'm going to be speaking about. And Nancy Gopelman mentioned some of her modeling work that we've been doing as a collaboration. And also Veronica Wiener, who's one of my graduate students over at MIT. I'll mention her work at the end. So what I'm going to follow is just this little outline here in talking about this. I'm going to talk a little bit, give you a little background, bring you up to date on sort of how to think about the problem of general anesthesia. I'll talk about our human imaging studies, then I'll talk about some human electrophysiology studies, both high-density EEG and intracranial electrode recordings. And then something new just to think about for the future, a new thing, like could we actually wake people up from anesthesia? So let me start with the definition. So what is general anesthesia? And this is an important place to begin, because I'll tell you right now that this is not an accepted definition. This is one that we've put forward because I think it's important. And I think part of the difficulty that has been had in this field as far as making progress in understanding general anesthesia is the definition has been kind of a moving target. So unconsciousness, you're not supposed to remember. It's not supposed to hurt. It's nice if you're not moving while the surgeons are operating. And stability and control of the cardiovascular, respiratory, thermoregulatory, autonomic, nervous systems. And it's reversible. So a drug-induced state that creates this. So if you take away this and you take away this, then you have these four by themselves. They could be synonymous with death. All right. So that's not a good thing. All right. So the whole thing is bringing you back. And as I like to point out, you may have heard me say this before, you go to a cocktail party and someone says, you're an anesthesiologist, ha, 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 you knock people out, right? And, no, any fool can knock you out, I bring you back. It's the reversibility, that's important, all right? So this is something that is often said. It's not clear how the anesthetic drugs work, and I just don't think that's the case. I think there's a lot known about how anesthetic drugs work. What happens is that we just haven't thought about it. Anesthesiologists haven't thought about it in a principled sort of neuroscience way. And I want to give you some sense of that today. All right? So a modicum of history. All right? So William Morton is credited with giving the first public demonstration of anesthesia at Mass General Hospital, October 16, 1846. And he was not an anesthesiologist. I don't think they existed at the time. But what he was a dentist. And what he wanted to do was he realized that he could give people a nice set of dentures if he could remove all their teeth. So he was looking for a way to painlessly remove people's teeth. So he came up with this idea of ether. And as you may or may not know this little bit of history, but the way he got the idea was that at the time, there used to be these things called ether follies, where people would sit around and sniff ether and get high. And as a consequence, just sort of observing empirically that someone having ether, hurt him or herself or cut him or herself and didn't feel any pain, and then the realization that maybe he could use this as his anesthetic. So he proposed this to John Collins Warren, who was the chief of surgery at Mass General at the time, and they decided to do this public demonstration, which took place on October 16, 1846. And it was Warren who said this is no humbug afterwards. And the reason that's important was that there was an attempt to demonstrate nitrous oxide anesthesia a year before, and it didn't work. They supposedly didn't give the guy enough. It wasn't these guys. It was another person. And it turned out it didn't work, and the medical students supposedly booed him out of the room and said, this is humbug. So the point that John Collins Warren was making was this really worked. But just to give you some idea of the impact that this had on medicine at the time, so prior to this, I mean, there was no way to basically to have analgesia for surgery. You know, the idea of biting on a stick or taking a swig of whiskey, I mean, that's what was done, or having someone knock you out, you know, physically. That's what the practice was. So this changed medicine overnight. So this was in October. Basically, by December, this had been attempted down in Australia. It had made it overseas about 6 weeks afterwards to Europe. And in Scotland, it was being used, you know, for deliveries. So this had tremendous impact on anesthesia. And just to be fair, just so this doesn't seem too sort of MGH-centric, that's why this is stated as the first public demonstration of anesthesia. So Crawford Long, who the hospital at Emory University is named after, is the person who's probably the first person to do ether anesthesia back in 1842. He didn't publish his results until 1849. Okay, factoid. All right. So, you know, so all those people at Emory there, just give them the proper due. All right. So, but the word anesthesia actually comes from Oliver Wendell Holmes Sr. He was the father of the Supreme Court Justice. He was considered a medical guru at the time. Morton wrote him, told him about this process, and he said, what should I call this? And Holmes is the one who suggested the word, you know, anesthesia, meaning lack of sensation. And it wasn't just sort of a flip thing. He actually thought about it a fair amount. He went through a whole slew of things, and he suggested anesthesia, right? So this is how modern anesthesia is basically done. We have a set of drugs which we roughly pick from to try to generate the various states. So if you look here, you know, for amnesia, maybe the benzodiazepines, inhalational drugs, analgesia, the opioids, and also the inhalational drugs, unconsciousness, barbiturates, and I put propofol in yellow because that's one of the things I'm going to talk about principally, and also the inhaled drugs. And immobility, we have the muscle relaxants, which are anticholinergics, and also inhaled drugs. So the inhaled drugs, which are still actually today ether-based. I mean, we've gone through a whole series of drugs and kind of come back to the ethers. You know, they're halogenated now, so they're less flammable and what have you, but they're still basically ethers. For a while, we were using an alkane, which was halothane, but all the primary drugs we use now, the inhaled drugs, are still ethers. So just a little bit of epidemiology. So the anesthetic exposure on a day-to-day basis in the United States is fairly substantial. So this figure here comes from the Joint Commission of about 60,000 people per day having general anesthesia. That's just for surgery, so that doesn't take into account other procedures, you know, medical procedures which may need general anesthesia, or let's say regional anesthesia. So it's a fair amount. And I've listed a few things down here as morbidities, but I'm just going to mention these two here, the postoperative cognitive dysfunction and also this issue of postoperative delirium in children. So postoperative cognitive dysfunction and the figure that I've taken here, about 30% within 3 days after anesthesia and surgery, comes from the study that was done by Terry Monk, who was at the University of Florida, who is now at Duke. And what she basically showed is that she had groups of patients, 1,000 in each group, sort of young, 18 to 39, older, 40 to 59, and then elderly, who were 60 and above. And she showed that if you did formal neuropsych testing on these patients, at 3 days, 7 days, and also at 6 months, that 30% of them had demonstrable postoperative cognitive dysfunction after the surgery and anesthesia. If you looked at the figure for the elderly patients was 41%. If you looked at the elderly patients, those 60 years and older, at 6 months, the fraction was still about 13%. So the idea that there's something going on, perhaps with the elderly, is something we see a lot. And we know just sort of anecdotally, you can anesthetize an older patient with less anesthesia, and people will come to us very often and say, you know, hey, look, you know, every time, you know, my aunt or my grandmother has anesthesia, there's this issue, you know, is there some way you can avoid, you know, giving her general anesthesia? Can this be done under regional? So that's not an uncommon conversation. On the other end of the age scale, the FDA has gotten really interested and has developed this partnership with the International Anesthesia Research Society to look at toxicity of anesthetics and drugs, anesthetics in kids. The concern is that these drugs may be toxic to the developing brain. Roughly speaking, that's what the animal model suggests, that a high fraction of anesthetics are toxic. And so this partnership, which goes under the heading of SMART TOTS, represents an effort to try to develop a whole research effort to investigate this. Right? So, how many people here have had anesthesia? Okay, great. How many people in the remote video room have had anesthesia? Okay, can't get their hands. All right. So how many people have seen other people get anesthesia? Okay, okay, I'm going to fix that now for the rest of you here. All right. So here's a gentleman. I mean, and I've shown this video before, but it really gives us some sense of like what's going on. That's why I like to use it. All right. So this is a gentleman who came for surgery.
And this is what I'm going to ask
there's nothing
you to
special.
do. Go off to...
There's nothing special going on. He's going to have a hernia repair, and I just asked him if we could go over and film him as he went off under anesthesia. And so I'm just going to do a few things. Some of this is just for the sake of illustration. But I just want to have him track my finger and do smooth pursuit for a second.
Okay.
Just to show you
now
that
let me
his
just
eyes
check one other thing.
function
What I'm going to ask you
normally.
to do is, so I'm just going to turn your head. Just let me turn it, okay? You don't have to, but I'm going to turn. Yeah, there we go. Good. I'm going to...
And I'm just turning his head, just showing you that, you know, he has normal dulls. I mean, I don't do this for every patient, you know, before I start anesthesia. You know, but just for the sake of illustration, that you turn his head one way, his eyes should go the other, you know, sort of thing, all right? Because the position of his eyes at the end when he gets anesthesia is going to be important.
Turn your head. Very good. I'm going to do it 2 more times. 3 more times. Okay. I'm going to pull down, you pull up.
Do you mind giving a little
And he's got normal motor
the
push.
rest
All right.
of the stuff?
Sure.
Just before we get started. Nice, slow, deep breaths, okay? Open your mouth a little bit if it helps, okay? This
Right.
is the most important thing we're going to be doing for you before you go off to sleep. Deep breath in,
Before we start
and then
anesthesia,
forcefully
we
blow it out.
fill the lungs with oxygen, have him breathe 100% oxygen,
breath.
create the margin of safety.
As deep as you can,
All right?
and blow
So
out.
that's what the nurse anesthetist
So I
is
want you
doing.
to just watch it. Just
So
You may
I'm just going to ask him to track my finger. Just track my finger, and we're just going to watch, you know, what happens as he gets the anesthetic drug. So when the words come on the screen, the anesthetic, which is propofol, which is an induction dose, just a bolus dose, about 150 milligrams, is going to just be pushed in.
feel warmth in your
Just watch
arm.
it.
So now
and
he's
what I'm going
getting
to
it.
ask you to do is, if you can no longer do it, I want you to tell me. You tell me if you can no longer do it. Just fantastic. Just keep doing it. Just keep doing it. That's great. Good. If you can no longer do it, just tell me.
So you see his eyes are fixed in the midline now.
Sir? Sir, can you hear me?
I mean, I know exactly. So
I'm just going to give you a
his
deep
latch.
breath here, okay?
Now she has to breathe for him. He's basically unconscious now. You can see I'm turning his head, and you see his eyes are fixed in the midline. Okay, and if I hadn't shown you this, you know, just had you come upon him, you know, this is a gentleman who's in a coma. You can see he was induced, you know, fairly rapidly, right? And so now the other thing which I'm going to show you here. So he's not breathing. We'll have to breathe for him. Now watch his arm. It's totally flaccid. All right, so just that quickly. And if you think about it, most of the times when you think of a coma or someone being in a coma, you think of them sort of being spastic. But this is something which is very characteristic of just getting an induction dose of propofol. Now he hasn't had any muscle relaxant yet. He just had the propofol. So that's just from that. All right. So the first thing I want to just illustrate is that just by paying attention to what happened there clinically and just going back and looking at a little anatomy, we can already start to think, or at least make statements about how the anesthetics might be working. So that's just what I want to do here now. So this is just a little bit of just looking at the anatomy. So let's just start over here. So here is the basilar artery coming up on the underside of the brain. It's basically sitting here, you know, going up along the brainstem. So here's the brain turned over, and we're looking at it from the bottom. All right, so the surface of Willis is forming there. And so if you look at where this artery is sitting, you know, the areas which are going to get anesthetic drug right off the bat are going to be the areas in the brainstem. So what's there? So if we look right here, just looking at this diagram over here, here are your respiratory centers, right? And I've just laid out all these arousal centers, which are sort of sitting from this, you know, this sort of hypothalamic sort of midbrain down to this sort of mid-pons area here, right? The arousal centers are sitting here. And as you know, the oculomotor nuclei, the inducens and the trochlear come out, you know, somewhere up here at the, you know, sort of the midbrain sort of pontine junction, right? So that would explain the eye findings that we see at the same time that he's losing consciousness. And then the other thing, which may be a little less obvious, is here at this sort of pontine medullary junction, you know, there's a whole slew of relay nuclei, motor relay nuclei, and in particular these two, the pontine reticular nucleus here, and then the medullary reticular nucleus. And it's interesting, when you have patients that have these, you know, pontine strokes, they very often show up with this sort of flaccid, a flaccid paralysis. And it's very likely that something, you know, quite similar, you know, is happening here. Or let's just put it out there as a postulate, right? And so these are the nuclei that control the anti-gravity muscles, sort of the arms and the legs, and, you know, and this sort of thing. So it would make sense that that the effects of the drugs at these centers could cause this type of lesion. So the point is that right there, you know, making a statement that we don't quite know how the drugs work, you know, just isn't the case. You can make a very sort of kind of back of the envelope look at the anatomy and sort of the little bit of physiology and make some, you know, some postulates. All right. Now, one of the first things that people often ask is, well, is anesthesia sleep? All right. So what I want to convince you of is it's really not sleep. It can't be. So first of all, if it were sleep, right, then we'd practice an entirely different way, right? We'd bring people into the hospital at 6 o'clock in the evening. We'd let them fall off to sleep. And when they fell off to sleep, we then like rush them to the operating room and perform the operation, you know, and then, you know, but we obviously don't do that. And even in the deepest stages of sleep, right, if you're in slow wave sleep, even with potting and poking, we can have you come to. And anesthesia can't, that's not the case. If you're at a plane of anesthesia, it's appropriate for surgery, right? The other thing is that if you think about what you need, I mean, surgery really is a traumatic insult. I mean, someone's going to, you know, open the abdomen or maybe open the head, transplant an organ, or, you know, repair a limb. And no matter how you think about it, that's a very traumatic experience. And what you need to be is in a state where you're insensate, both in, you know, sensation sense and sort of a physiologic response sense to that insult. So it has to be something like, or, you know, general anesthesia. So having said that, if you just, so now just thinking about it logically, but then if you actually just look at EEG patterns, so this is just one illustration to demonstrate that they're not, you know, the same state. So if you look here, this is someone who's awake EEG. This is someone who's awake with their eyes closed, this sort of alpha rhythm, all right? As you give a little bit of anesthetic, you get this state called paradoxical excitation. You know, the drug is supposed to slow the brain down, but paradoxically it seems to excite it. And, you know, to give you some intuition about this, this is what people were after in the ether follies. They wanted to get to this state here, you know, without getting to here. Or this is someone who's a little bit high on alcohol. Here, you know, alcohol is an anesthetic, you know, kind of the same way, right? Then as you get deeper and deeper, more, if you increase the dose of anesthesia, and actually these are actual traces from one of our patients on propofol. I mean, this flat line here isn't. I just drew that in there just for the sake of completeness. That didn't happen, all right? All right. So as the EEG slows, you start to see some distinct patterns here. There's actually an alpha pattern here. There's a delta pattern. We'll talk more about that later. And here you see this burst suppression. And I just want to mention that because this is a very deep state of anesthesia. And what I've put here in parentheses are corresponding states of coma that can be seen that look just like anesthesia. So someone in a coma can have, you know, like any one of, let's say, like these patterns, or maybe even this one here for that matter. And that contrasts quite a bit with what you see in sleep. And as you know, when you fall off to sleep, you go into non-REM 1, non-REM 2, non-REM 3, all right, slow wave sleep. And then you oscillate back and forth to these, then to REM, And then you go back and forth between, you know, the non-REM and REM states of the course of the night at about a 90-minute cycle. You have your, you know, most of your most restful sleep early on, or your deepest sleep early on in the first 2 REM cycles, non-REM stage 3 or slow wave sleep. Then after that, you may not go as deeply. And I've drawn this like this on purpose just to illustrate that depth-wise, these states are quite different. So one thing you can always say is that you never have anything like burst suppression in sleep, right? That doesn't appear. And in fact, burst suppression is a very deep stage of brain shutdown. To give you a sense, you know, usually when patients have like diffuse anoxic brain injuries, seeing a burst suppression pattern is not uncommon. And I'm going to show you towards the end that this gentleman that was in the video there, that he probably went into burst suppression within about a minute or so. So this is a very profound state that we can take you to very rapidly by giving you an anesthetic drug in a bolus fashion. The other thing is that there are other states in which you see this, like Ohtahara syndrome, which is one of the infantile encephalopathies, or in hypothermia, again, with profound sort of brain shutdown. And then, you know, coming down here to, let's say, an isoelectric state. All right? So anesthesia not looking like sleep. All right? We've created a problem for ourselves in anesthesia because what we do in anesthesiology, because what we do is we say sleep to patients. We say, you know, excuse me, Mr. Jones, I'm going to have you go off to sleep for your surgery. I mean, you can't go up to him and say, excuse me, Mr. Jones, I'm going to put you in a reversible coma, you know, for your operation. So, but the problem is that when we come to speak technically about the process, we're very imprecise. And this imprecision carries over when we, you know, speak to the public and we write this in our textbooks. And so these are things which are taken from the literature. So this is a comment by an anesthesiologist, actually a chief of the Department of Anesthesia here in the country, who said that although the drug, this was right after the results on some of the autopsy results came out on Michael Jackson, he said that although the drug, meaning propofol, puts patients to sleep, that sleep isn't restorative, right? This is a statement which comes from one of our anesthesia textbooks, Miller, the most recent edition. Barbiturates produce the clinical effects of sedation and sleep, right? Here, even the New England Journal isn't immune, all right? So this is a discussion that was being had about lethal injection and the types and how the drugs are used. And they said that the first drug is thiopental, also known as sodium thiopental or pentothal, which is a barbiturate which is designed to put you to sleep to create amnesia and anesthesia. And then here, this just came out in the Canadian Journal of Anesthesia. An anesthesia researcher is making the statement that the similarities essentially in the state of the brain between sleep and general anesthesia are actually more striking than different. I mean, I think nothing could be, at least from my perspective, nothing could be further from the truth. All right? So let me talk about how people have thought about how anesthesia might work. What are some of the current ideas? So one idea is that maybe there's a thalamic switch. So Michael Alkier has talked a lot about this and proposed it as a way that the anesthetic drugs might work. And then in an editorial written by Cliff Saper and Bev Orzer, they proposed this idea that there may be like these flip-flop switches involved in like some of the sleep pathways. Right? And this idea of a mesopontine tegmental anesthesia switch or area comes from Marshall DeVore, who did some studies where he injected anesthetics locally into rats, sort of bilaterally, in this mesopontine area. And some of the phenomenology that I was showing you there in the video, in the gentleman, he showed it occurred in the rats, like the atonia, the seemingly loss of consciousness. And then Tony Huditz, kind of based this on some of the ideas that Giulio Tononi has been putting forth about consciousness being generated by cortical connectivity, that loss of consciousness may be generated by a loss of this sort of cortical connectivity. All right? So what we set out to do is to do some experiments that would give us some empirical evidence on how these states might be created. So the first one I'm going to tell you about is our functional imaging studies. And in these functional imaging studies, what we did was something extremely simple. Why not just image the brain, and while you're giving someone a dose of a drug, an anesthetic drug, and then look to see what parts are, how they're changing their activity, image and also measure EEG at the same time. And so we did this and imaging, measuring the auditory steady state response, and we had a very simple task, which was the patient listens to a high-low tone, indicates when it's high and indicates when it's low. So that's our measure whether the patient is conscious. And we did standard monitoring of the physiologic variables, and in particular we made sure to control the end-tidal CO2, because if you don't, then what will happen is you'll get a washout of your image. So this is just to illustrate the design of the protocol. It's extremely straightforward. We're giving a computer-controlled infusion of the drug propofol, giving increasing doses like that. At some point, the subject will lose consciousness. We're imaging at the same time, and we're continuously collecting EEG. And then there's a click stimulus being played also, but the main thing is we have this high-low tone that the subject has to respond to. Right? And so that's going to be our clinical. So when you stop responding, that's the indicator that you've lost consciousness. Now, we had a challenging technical problem to solve, and that is that patients, as you saw in the video, stop breathing, all right, under anesthesia when they're induced. So what we had to figure out was a way that we could continue to image and collect EEG after people have lost consciousness so we could have them go through this transition. So what we did was we decided to impanel patients who had tracheostomies, and we got tremendous help from the International Association of Laryngectomies. So these are patients who have had laryngectomies either because they've had throat cancer or perhaps because they had a dysplastic growth or maybe they had trauma to the neck, and they've ended up with a tracheotomy or a tracheostomy. And the idea was that, as the little diagram here indicates, we could place a tracheostomy tube in them before we started and then hook that up to our breathing circuit, and we'd be in a situation where if they stopped breathing, we could just assist them through this period after they've lost consciousness. All right? And our thinking was, and I'll put up, this was our thinking before we started the study, if we're having people listen to auditory tones, then we're going to excite this pathway going from cloacular nucleus to superior olive, IC, MGN, up to A1. So, straightforward study, basically play a tone, image, measure EEG simultaneously, and watch to see how the various brain regions change their activity, right? So, this is an illustration of some of the data from the study. So these are the behavioral data down here. So the person's responding. They've received no drug, okay? And this is a 15-minute period here. And so they've gotten one of these little tests about once a minute. And you can actually see the length of the line tells you how long it took them to respond. So that's about 1 second there. And then the other thing is the length of the line tells you how long, the color of the line tells you that they responded correctly. So they're blue, so they're getting them all correct. And as I said, that's good because they've gotten no drug, all right? And then you increase the dose of drug, so you infuse and you try to hit this target of 1 microgram per cc, and this is over a 20-minute period. The lines have gotten a little bit longer. One drops out. This one's now red. All right? And then over here you see no responses, and over here. So you continue on up, and after this point here, the subject is no longer responding. So if you look here in the imaging data, so here's an axial view of the brain, and here's a coronal cut. And these are the auditory areas here, primary and secondary. And the person's listening to the tone, you can see those areas are quite active. And then as the subject starts to get more drug, the activity here is declining. And then here, interestingly enough, in these deeper structures here, the activity is seemingly coming back. Now, so just to let you know a convention that we used in analyzing the data, so fMRI images, we fit a regression model. We're estimating the coefficients. The coefficients are normalized. There's a fixed level of thresholding across all the images. So the same level of thresholding is used here, 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 and here. And what we're reporting are the coefficients whose T ratio or F ratio, whatever you want to call it, is larger than this threshold. So these are only the highest peaks in the mountain range, at any one time. They have to be above a certain height. So the thing that we're observing here is that the person's executing the auditory task, and at least by this measure of activity, which is BOL, blood oxygen level, activity, the deeper structures here are not active, but we know they're active because obviously this is where the auditory pathways come through here to get to the primary auditory cortex, but they're not active at a level that would generate activity above this threshold. Let me say it that way. However, at a deeper stages here, when the subject has lost consciousness, these brain structures are actually active by this criterion, all right? So the same thing, just in another subject, same paradigm, getting everything correct through the first two levels. This person is seemingly not responding, starts having difficulty at level 2 here. Some of them are wrong, missing some, the response times are longer. Finally, in here, no longer responds. Activity here, less activity now, less activity, and again, these deeper structures, sort of come back. So let me just cut to the chase on this. Just one other illustration of this. So this shows this sort of reactivation or activation, however you want to call it, in the thalamus at these deeper brain states here, and maybe even as far down as cochlear nucleus on these slides. So the statement is that instead of these areas shutting down, they're actually becoming more active. Right? So what Patrick did, so this is Patrick Purdon's work, he actually just made a composite figure over all of our subjects. So here is the baseline. This is the level just before the subject's lost consciousness, so axial, then again the sagittal sections here. And then now, less activity, again, by a similar thresholding criteria. And again, it's not that there's probably zero activity there, but just zero activity relative to a thresholding level. Right? That's important to keep repeating. But then, when you look here, you see in these sort of deeper structures, thalamus maybe all the way down as far as like, cochlear nucleus, you have actually quite a bit of activity. All right? So, did I expect that this would be the sort of patterns we would see? No, I can't say that I did. To be honest with you, what I expected we would see is just sort of different areas breaking down in activity. I didn't expect to see something like this. And so when Patrick looked to try to put it together, what we realized was this was the hypothesis, this is where our thinking was when we started, that we'd be activating this sort of ascending auditory pathway, and we ourselves hadn't given much consideration to the descending pathways. And as I'm sure, there are people here who know more about this than I do, the descending pathways coming from A1 project back to, MGN, IC, and there's evidence they may even project further down here. Now, the anatomy gets to be the detail anatomy gets to be a little difficult here, but at least to here, this is probably an excitatory pathway synapsing on inhibitory interneurons. So what you have is basically a negative feedback pathway. So if in inducing the anesthesia, what you're doing is you're anesthetizing the cortex and you've removed essentially the descending inhibition, then as you reach deeper stages of anesthesia, one interpretation of what I'm showing you is that these areas are becoming more active. Right? Now, so conjecture, but is there any neurophys that goes with that? So this is taken from a review by Jones, which is written about 10 years ago, in which he mapped out these sort of different thalamic pathways. So this is this non-lemniscal pathway projecting from layer 5 back down to the reticular nucleus of the thalamus and also down to the brainstem. And so this is a much more diffuse pathway as opposed to sort of this core lemniscal pathway, which is much more sort of focal in its extent and its synapsing. And then this is data which was done from experiments done by Tony Angel, 20 years ago, in which he was recording, in the cortex. So this is cortical depth here in millimeters, and he's got the layers marked over here. So this is like layer 4, layer 5, layer 6. And what he's showing is that a light anesthetic plane, if you look at the latency until he observes activity, there's actually very robust spiking activity in the neurons here, sort of across all the depths, even at a light plane of anesthesia. When he deepens the anesthesia, the cortical activity dies out, but what he showed was that there's actually a greater decrease in the area in layer 5 activity. And layer 5 is actually where this inhibitory pathway is coming from. So our interpretation is that this gives us an explanation for what we're seeing. It's where this inhibitory pathway would be originating from, and what we've managed to do is perhaps take it out. right? So what I've just shown you is that with these subjects is that loss of consciousness, you get this reduction in activity in the auditory cortex, that some of these lower structures, perhaps cochlear nucleus, thalamus, are actually active in this state of profound loss of consciousness, and that this may be due to this disinhibition, all right? So those studies were a challenge to do, and one of the things that we wanted to try to understand was, well, what happened when patients lost consciousness and recovered consciousness? So we decided to put the imaging aside and just move to high-density EEG recordings. And we have a very similar behavioral paradigm, but instead of imaging, we recorded 64 leads of EEG, and we have 3 types of stimuli. And what we did here was make the stimulus composed of auditory tones, both 40 and 80 hertz, and also neutral words as well as a subject's name. So on one trial, the subject will hear its name. The next trial, they'll hear, a set of clicks, 40 or 80 hertz. On another trial, they'll hear a neutral word, right? And the idea is to try to understand if there are different probes that can be, because one of the things we ask patients, just clinically, right, the clinical relevance of this is we ask patients, what do you like to be called? Fred, Dr. Fred, Dr. Smith, or what have you. Because that's what we use when we were letting them recover from anesthesia. We try to use a probe which is salient. So we want to try to test this idea. So this will allow us to look at both loss and recovery of consciousness from general anesthesia. Here's the experimental paradigm, very similar to the previous one, increasing doses of propofol with a computer-controlled infusion, and then stepping it down. All right? So we can watch people as they lose consciousness and then watch people as they recover consciousness. And this is just the color coding for the montage. I'll go over this again later, but we have like 64 leads of EEG here. And these are just the trials. So, auditory tone, then some sort of neutral word or name, auditory tone. All right, so each one of these trials is about 20 seconds. Right? So I just want to explain one phenomenon, then I'm going to show you a little video of this, right? So this is a frontal EEG lead, a frontal channel, and here's a back channel, an occipital channel. All right, this is the entire experiment, all right? The entire experiment, right? So we have our subjects lie there with their eyes closed to start off, so they have this very strong alpha rhythm, which you can see posteriorly, right? Then, as they start to lose consciousness, here's the paradoxical excitation. The alpha actually drops out. This is in the back. The alpha rhythm drops out. There's a very strong slow or delta oscillation. When they recover consciousness, this fades away, and they're back at the alpha rhythm that you saw when they were awake and with their eyes closed, right? In the front, you see something entirely different. In the front, there's basically no real alpha oscillation at all. You see this period where they lose consciousness. And if you look carefully at this here, this alpha here is actually a little bit higher than the alpha that you saw down here. If this was at 10 hertz here, this is going up as high as 12 or maybe up to 15 hertz. Then this settles in. There's also a slow oscillation, a delta oscillation here during the period when the person's unconscious. When they come back, that disappears, all right? So there are these sort of different patterns in the front and the back. So let me just illustrate this with a little video. So this is the front, this is the back, occipital, left, right, and up here you can see the drug dose that the person's at. So this is baseline. So there's that strong occipital power across the back of the head. There's not very much at all, which we see sort of up here, up in the front. And so I'm just going to play the video here, and you can actually see, you're going to see this phenomenon of anteriorization. You're going to see the power in the electrodes move from the back to the front of the head, and then when the people recover consciousness, it's going to move back from the front to the back. All right? And this is this well-known thing called anteriorization. So I'll just show you this here. So they're still just at baseline. Now they're getting the first drug level. You can see this is disappearing. 2, this is starting to appear from the front. And it's not subtle. You can see the alpha and delta oscillations there. 4, and now at 5, it's very focused. Different down here, just delta. Now this is the most profound level of loss of consciousness here, which I'll show you why in a second. Now as you start to dial back on the drug, this disappears, and the power returns back here in the back of the head. So this phenomenon of anteriorization, the power moves forward across the head, then it moves back as you recover consciousness, all right? And the person is back, emerged, all right? So, and this just shows you like the whole study across one subject. So this is the EEG recordings. This is the spectrum, 10 hertz, start to lose consciousness. There's the paradoxical excitation. And the reason I know they're starting to lose consciousness, all these green marks here represent correct responses to like the clicks, and the red and blue marks in here represent correct response to the words or names. Here they start to break down a bit. There they lose consciousness. There's the paradoxical excitation. It declines into this sort of alpha oscillation, which at first is a little bit higher, then it settles in. At the same time this comes on, there's the slow oscillation. When we start having them recover, the EEG, this power dissipates. The slow oscillation starts to break up there, and they're back responding, and there's their EEG. And actually, it's interesting. See, this isn't quite like that. It's a little bit, a little bit different. All right. So, in some respects, what I've shown you, at least on the induction side, are things that are known. I mean, people have known that these alpha oscillations like this have been there for a while. The question is there any structure in them? I mean, we showed you that there was all this activity across the front of the head, but is that activity in some way coordinated, right? So to look at this, Aylin Simonser, who's my postdoc, came up with this idea of what's called global coherence to analyze this. And there are a number of ways of explaining it, but the simplest way to think about it, all she's doing is an eigenvalue, eigenvector decomposition of this cross-spectral matrix. And the idea is sort of the following. What you want to know is if you think of this as like being like the head, right? And the question is all the activity coming symmetrically from everywhere, in which case there's no real interesting direction, right? But if the activity is coming in an oblong way, let's say from the front, then there's an interesting direction, which let's say where a main eigenvector would tend to lie, and a high fraction of the variation at a given frequency would be explained by that direction. So that's what she's looking for here. And the way this is computed by just taking this matrix, taking the largest eigenvalue, taking the ratio to the sum, and that is a measure of this thing called global coherence. This is a number which is going to be basically between 0 and 1. Right? Easier to explain in a picture. So these are subjects. These are 6 of the subjects. I mean, there are 10 subjects. They show exactly the same thing. So here's subject 1, subject down to 6. This is the entire experiment. And this is this global coherence measure here. And here's the color scale for it. All right? So if there's strong coherence at a frequency, you see a very rich color in here. So in here, you see a rich color across all the subjects. Now, this is just the behavioral task. So at most, they could have 4 correct responses on any trial. And you can see across here now the drug is going up, up, up. It's at a maximum here. It's coming down, down, down there. They're having trouble responding. Now finally stop responding altogether. Here, this person, trouble responding, stops responding altogether, comes back over several trials before, and doesn't really perform consistently until pretty much the very end. This person stops responding, is out, stops responding again, starts responding again. And the point that I want to make here is that in this area here, across all the subjects, when they were profoundly unconscious at the deepest doses of anesthesia, there's this strong coherent activity at this alpha frequency. So this is about 10 or 11 hertz across all the subjects, right? And the question is, what's up? So where is that coming from? So what Aylin did was she made this little color map here to give you some sense of what we can look at a plot which will tell us where that coherent activity is arising. So one of the things that you can ask is if you have these sort of, if you have this eigen matrix and it transforms your original data into this new space, like what are the weights? How much of the weights are coming from which direction? So that's what this color map is designed to illustrate. So the key point that I want to make is that, so these are the weights which actually sum up to 1, right? And then in here, in these regions where the subjects are profoundly lost consciousness, the colors are coming from the front of the head. All right, so how do I know that? Because if you look at the color map, this is the front sort of part of the head here. And that's what these colors correspond to. And it's only later that the last part might come from the reddish part up here, the purplish part up here might come from the back. This is in contrast to initially when there may be coherent activity, but it's coming from the back of the head. And this makes sense because this is the alpha oscillation, which is occipital, which is just having your eyes closed. So the two-sentence punchline is that this coherent activity is coming from the front of the head at the time when the person has profoundly lost consciousness. All right? And so this is just by way of illustrating that just across one subject, the whole thing. They're the behavioral responses. They stop responding. Just to show you that lines up at the time that you have this change in the spectrum here, the alpha and the delta oscillations. Here's where they're coming back. They're starting to respond again. Those are the clicks. Those are the words and names. And there's the global coherence. So at the time when you see this very deep alpha pattern here, delta pattern here, you see this strong coherence. And what's interesting is, notice how the delta pattern is very strong. In fact, it's just as strong as the alpha pattern, but it's not coherent. In other words, this coherence is not in both frequency bands, it's just in this alpha band. All right? Another subject sort of showing the same thing. So with the help of Nancy Coppell, we've done a little bit of modeling work to try to look at this. And so the modeling at the moment has helped us fill in a hypothesis of why this may be occurring. So the conjecture that we're making at the moment is that with the decrease in alpha with the GABAergic drug like propofol, which acts both up in the cortex here as well as down in our little rendition of the thalamus, we actually create a state where the cortex has decreased activity, the thalamus as well has decreased activity, but the thalamus then goes and has this sort of rebound, it's hyperpolarized, and so it has rebound spiking. And what we've been able to show, or at least to say what Shenung Chen has been able to show, is that this can generate this alpha oscillation, and this alpha oscillation would actually entrain the cortex. Right? So we have a thesis for this. So then this would put together essentially three things. The thalamus being active at this deep stage of anesthesia from the imaging study, this seemingly strongly coherent activity across the front of the head, which we come from the EEG studies, and this modeling work suggesting that the thalamus could play the role of the center which is helping to engage this and sort of generate this alpha oscillation, which we would postulate would engage the anterior forebrain. All right? So that's basically what I've just said there. All right? So I just want to show you two other things very quickly, 2 quick points. All right? So we are actually able to do some intracranial recordings from patients that come for their epilepsy surgery. And this is thanks to Ahmad Eskandar and Sid Cash, so neurology department, neurosurgery department. And I want to illustrate something about anesthesia and how profound the effects are. So this is a patient who has the electrodes implanted, and this is her this is her spectrum across time. So each one of these is 30 seconds. All right. So she's lying there before the start of the surgery. At this point, she gets propofol. All right. Now, so not much happens, and within 30 seconds, you see the paradoxical excitation. All right. She loses consciousness here, and you see this activity out there. There's the burst suppression. So this is 30 seconds. That's about a minute. So within about 1 minute and 20 seconds, she's in this very profound state of burst suppression. And as the length of the time between the bursts gets longer and longer, she's actually moving to sort of a deeper and deeper plane, or it's having a deeper and deeper effect on the brain. The point is that this profound state of unconsciousness can be generated within a minute. I mean, it doesn't take very, very long at all. And so you're saying that you're putting someone's brain in a state which is like being in a profound coma, in a minute or in a little bit more than a minute. And you can ask the question, is that the sort of thing you should be doing? Is this the way anesthesia, should occur? I mean, so without knowing that this is happening, the question can't even be posed, right? And then a second point that I just want to make about coherent activity. So in this particular patient, Veronica Wiener, who's doing these studies, is recording from areas here in the temporal lobe. And the electrodes are obviously placed sometimes symmetrically, but very often based on the hypotheses about where the patient's seizure foci are. So we have experiments of nature. I mean, we just can't go in and put the electrodes like, everywhere we would like to. But even with this, I can make a point here. So this is the spectrum from one pair of electrodes. The person gets the drug. You can see this paradoxical excitation. You can see how the activity is decreasing over time. The same sort of thing here. Simultaneously, here's what's happening on at the other electrode site. Different appearance, same general pattern. But what I want to point to is here. This is a measure of the coherence between the two sites as a function of frequency. So roughly in here, starting in here, somewhere going between about, let's say 4 to maybe about 15 hertz, there's this very strong coherence which is above 0.8. So in other words, you have these sites in the brain in which as the person is going to deeper stages of anesthesia, instead of them breaking apart, they're actually becoming more coherent. All right? So this is just to point out that this idea of loss of consciousness being generated by having hypersynchronous activity or coherent activity is not unreasonable, and we can just sort of see it here, even if you don't believe, even if not just sort of maybe in some sort of thalamus engaging with the anterior forebrain, but you can actually see it in these sites here, in this case in the medial temporal lobe. All right. So just one little quick sort of maybe look at the future. I've been talking a lot about anesthesia, and what we do is we induce patients with anesthesia, and when we let them recover, we just let the drugs wear off. And we just sort of wait to see what happens. And, and part of the art of anesthesia is, the surgeon finishes, the last bandage goes on, and then you kind of time it so, you can just take the drapes down and the patient just wakes up and sort of roll right out of the room, okay? That only happens in the movies, all right? So if we've actually anesthetized the brain, maybe we should try to bring it back, all right? So Ken Salt, who is one of my colleagues there at MGH, has been working on this particular problem, and I just want to show you some work that he's been doing in this way. So this is the one little sort of animal vignette. So this is one of our rat volunteers, and he's lying on his back. He's in a chamber here in which he has isoflurane, standard inhaled anesthetic, and he's been there for 20 minutes. Okay, he's got a vein in his tail here. He has some EEG leads on, and so what Ken is doing here right now is just injecting some normal saline. Just going to inject some saline. And not a lot happens. The rat is still there. And so, again, so 5 minutes later, so we've been looking at a number of ways of trying to do it, trying a number of different drugs. So this is one of the test drugs that Ken is looking at. So now he's going to just put it in the line. Now he just need a flush to sort of push it through. So now just the saline flush. So now the anesthetic is still there. He's been there now for 25 minutes or more, just sort of breathing this anesthetic in. But, with these experimental ways, maybe we can bring him out of this. And so it doesn't count until he turns it, until he's sort of like right. But what he's caught in the wires there, But he's working hard. So, maybe possible, all right? So like, right now, what we would do is we would try to time, how the drugs were given, we would, thank you. You all know I don't manage my laptop too well now. All right, so not a Novo message. All right. So, maybe a new idea, all right? It's at least something that we're experimenting with. So, this is kind of roughly, what I consider the anesthesiologist's view of arousal. I mean, I talked about the relationship to sleep, and you can see there's an obvious relationship to like coma and what have you. And as we change these sort of EEG patterns, it's not hard to imagine that there are, links to like all of these. As we change the way we dose the drug, we can generate pretty much all of these states. And I think this is one of the things which is missing in anesthesiology. I mean, anesthesiology really offers this unique opportunity to sort of interface and be like a real bridge and link between clinical neuroscience, and we haven't really done that yet. And I think that, herein lies an enormous opportunity. And then finally, just to summarize the main points. So loss of consciousness of what I've shown you. So the loss of consciousness with propofol induced by decreasing this activity across the cortex, perhaps getting this thalamocortical loop in a setting where thalamocortical system is a situation where it's engaged in this alpha oscillation. So while you're unconscious, you may have this very profound oscillation which is keeping you there. And other areas of the brain may be oscillating as well, which contributing to sort of the loss of consciousness. And then this sort of disappearing, like when you come back from anesthesia. And then the final point is that if nothing else, I just want to try to convince you that this is not sleep, and it's more like a reversible coma. All right? So I'll stop there. Thanks.
Are there any questions? Please go to the mics.
I'm not offended if there are no questions.
Well, let me just ask you a question to start. There is also a lot of talk about coherence as a property of attention, and at different wavelengths, and how do you talk about these two different states?
No, I'm glad you brought that up. So normally when people talk about, normally, in one setting when people talk about coherent activity, it's like in the gamma band, so up in the 40, 80 hertz range. And and people even suggested looking at this sort of loss of coherence in the gamma band as a way of measuring depth or changes as people transition in and out of anesthesia. And, we've not found like really compelling things to look at there. I mean, they're not, the change that I'm showing up here are not subtle at all. And, we've had to redo the spectrum on a different scale to even sort of see what's going on in the gamma band. And it's just not as compelling as I would have thought, to be honest.
Could you tell us a bit about what's the source of the frontal activation during the period of the loss of consciousness?
Yes. So here's where admittedly the story gets a little murky, right? And I'll admit that we don't have like all the details worked out. But so all the cortex is basically not shut down, and to some extent the level of kind of cortical hum, if you would, is probably indicated by like the delta the slow oscillation. We sort of think that that's probably coming from like the cortex, right? So steroids showed sort of the mid-90s, that if you look specifically at burst suppression, right? What happened was, if he looked at the number of cells, he's recording from the cortex as well as from the thalamus, and he's actually using anesthetic drugs, both IV drugs as well as inhaled drugs. He showed that a high fraction of the cortical cells that he was recording from were basically become inactive, and about 30 to 40% of the thalamic cells were active. Right? So we're at a state which isn't burst suppression. We're sort of above that. So let's assume, just for the sake of discussion, that there's something similar going on. There's a decrease in the amount of cortical activity there, and the thalamus isn't inactivated, but maybe in this sort of hyperpolarized state. So it's actually spiking in a different pattern as opposed to just sort of in its normal throughput way. So our conjecture based on the modeling is this engagement between thalamus and cortex, which is giving us this oscillation, coming from the front. That's the guess. And the obvious experiment now is to actually, go back and, in an animal model, put electrodes in those two sites and see if that's the case.
I really enjoyed your talk. My question is that in the first study, you demonstrate from the fMRI and EEG experiment that what it looked like on the illustrations is that very promptly after the subject regains consciousness, they go right back to clicking away, either low pitch, high pitch. Is that actually how it is? Given you were explaining that the amnesia is something that's experienced.
I'm sorry, the amnesia?
Amnesia, as in don't subjects lose the ability to remember what they were doing, but then after regaining consciousness, they remembered basically up to the moment before they lost consciousness of what they were doing. Is that
so somehow
correct?
This disappeared. Is it possible to get this back up there? Great. So here's what I was showing. Okay, so here's the whole study. So there's the performance. Let's say like the clicks, okay? And then there's the words. So they're out in here. And these we marked anyway. I mean, we think these are movements. Like we have the video, we can see that they were moving but not responding, but we just put them in there anyway, all right? And now here's where the electrophysiology is changing, and here are the behavioral changes, okay? And so you're asking, shouldn't they have forgotten what they were supposed to do, basically? They remembered. I mean, they did. So the question is, what we want them to be is amnestic, thinking about anesthesia now in the operating room, what we want them to be is amnestic for this period, all right? And, we haven't done any sort of formal testing on that, so do you remember, like, what was going on? And I can tell you the room is totally quiet. There's nothing to sort of engage them. The only thing only sounds that are being made are the sounds made by the physiologic monitoring. So this is what every subject, basically does. So they remember what they were trained to do, but I haven't formally tested it. They're amnestic for this period here.
And is that something that's looked at, that you're interested in looking at? Is maybe where the difference in brain activity is happening?
No, that's a great question. So, we made a decision right off the bat. So make a definition of anesthesia and then try to pick a component and try to study a component. And what we figured out was it would probably be easier to study coming in and out of consciousness. Because even those things you could then take into animal models and look at things, sort of almost parallel, either rat or maybe, primate models, non-human primate models. Memory is a tricky one, because, how to do that. And there, not that there haven't been studies under, looking at this, but we decided to start with the unconsciousness first, and then, maybe subsequently we'll look at amnesia.
Thank you.
So, is the pattern similar in the animal model versus human?
I'm sorry?
Are the patterns you're observing similar in the rat versus human?
Yeah, these patterns here, like, let me just show you something here. If you go back, like, even back to here, these patterns here that I'm showing, they're extremely similar. So they're extremely similar up to just a little bit of difference between inhaled drugs and all the drugs that work, let's say, via GABA-A inhibition, all right? The one which is a little bit out there, there are two that are sort of a little bit different. One, actually three probably. So the opioids, different, okay? The ketamine is different, much more active. And dexmedetomidine is different. And actually, dexmedetomidine actually looks more like this, actually, believe it or not, right? Across the animals, they look, between animals and humans, they look very much the same.
How about the patients who has delirium? Is there any, did you follow up some of the patients who might have other adverse events?
Like a signature for delirium, per se?
Yes.
You know, not necessarily, because what I can tell you is, if you look here, like, you know, we now have in our operating rooms there at MGH, we actually get this sort of trace. We actually get, with these SedLine monitors, we get the spectrum like in real time. And this is exactly what you see when people, you know, recover. And when they get in here, right, you could have someone who's recovering very fine, you could see perfectly well, you could see this pattern here, or they could be, you know, delirious. I mean, there's we haven't seen like a nice sort of clean signature of delirium. But then I can also say I haven't had like, you know, tons and tons of like, you know, cases of, you know, delirium either. So I don't know of one right off the bat.
Okay, thank you. I'd like to invite everyone to a reception which is down the corridor behind the auditorium, past the elevators, in the atrium. Thank you very much.